Welcome to Project Echo. We're looking forward to having you join us today. And I just want to remind our participants today that disclosures have been sent out in the email. Julie was able to send you the links to the pre-test, the post-test, and the evaluation. So please do make sure that you've been able to complete the pre-test prior to the start here so that you can receive the appropriate credit. The red, white, and black Project Echo signs, you may recall, denote that the subject matter experts are available for the discussion, and we're looking forward to some questions and discussion after the didactic today. We won't have a case today, so we'll be limiting our time to that. Also, can you mute your audio when you're not speaking? But if you'd like to make a comment, please feel free to unmute your audio to ask that question or make that comment, or otherwise, if you don't want to interrupt at that moment, you can also use the chat feature, and we'll be taking those questions and monitoring the chat box with regard to questions and comments you may have. Next, I'd like to introduce our didactic presenter, Dr. Anne Lindsay. Dr. Lindsay has served in the public health field for more than 30 years. She owned a wellness consulting business for almost a decade, which included serving drug court clients and prison female inmates specifically. Currently, she is an associate professor of public health and exercise science with the University of Nevada, Reno, the extension in Las Vegas, and she received her undergraduate degree at the University of California, Santa Barbara, and a Master's of Science in Exercise Physiology and a PhD in Public Health from the University of Nevada, Las Vegas. Since 1997, Dr. Lindsay has studied women in correctional settings with a focus on substance use, misuse, also nutrition, physical activity, eating pathology, and body dissatisfaction. She has developed and implemented an evidence-based program for early release credit for women housed in the Nevada Department of Corrections, as well as implementation in the municipal judges' specialty courts and women's in- and outpatient treatment centers. Dr. Lindsay has served on numerous advisory boards, published several papers, fact sheets, and related curricula. And Dr. Lindsay, it's my pleasure to welcome you for a didactic concerning these important issues.
Thank you. Can you hear me okay?
Yes, very clearly.
All right, and let's see. Can you see my slides?
Yes, I think if you just begin the full screen presentation mode, then we'd even see them with a larger context. So
okay. Is that better?
Perfect. Thank you.
Okay. All right. Well, thank you for having me. As you know, I'm not a clinical, I'm an educator. So a lot of the programs that we do, or all of the programs actually that we do, we supplement existing treatments. So I'm going to mention a program at the end that people could have access to that could also utilize to subsidize, current treatment. But I want to talk today about some of the gender-specific issues, which is what I've done my research on for many, many years. And before we get into that, let me see if I can move this so I can see my slides. I wanted to just give you a couple of statistics that are maybe common to many of you, but maybe not. One, on the left side of this screen, we're looking at the number prescribed per person. On the right side of the screen, we're looking at the opioid deaths. And you can see the darker the color in each case, the higher the rate. So definitely West Coast is a big issue, North, South, West Coast, so the entire West Coast, and also the Southeast area that you can see that are some of the larger issues that we have. I don't know how to stop these screens from popping up. As far as geography and opioid deaths, when we look at that, the highest rate is in women ages 15 to 44. These are from the Kaiser Foundation, the Appalachian, Southern and Western states, as I mentioned in the previous slide. And these look at opioid deaths by gender, so male and female. And if you look at the United States, that's pretty typical that we know if we look at opioid deaths, opioid treatment, no matter what data that we look at, typically it's about a 65 to 35 for males and females. However, I pulled up a couple of the states as examples where the females are actually higher than the males, and in some cases, There's a lot of other states where it's about 50-50. So overall, when you look at the United States, it's one thing, but when you look at the Western region, it's a little bit different. Opioid deaths in women have increased nearly 850% in the last 10 to 15 years. You can see that everybody has gone, or all of the cocaine, heroin, they've all gone up a little bit, but opioid has really, really increased in women. These are just a couple of statistics. 850% in opioid-related deaths. It's increased 471% in prescription opioid use, which is about twice the rate of men. Heroin deaths, more than twice the rate of men. Very common in the reproductive age female, has had a 400% increase in overdose. And then, of course, hospitalizations involving pain relievers, and heroin has increased 75% in women versus 55% in men. And this is basically in the first 15 years of the turn of the century. We also see it in older women older than 65, that nearly a third of older women reported prescription opioid or alcohol use in the past 30 days. 1 in 4 of them take at least 5 prescription drugs, which is super common. And sadly, a lot of them don't know why they take it. A lot of them don't know how to take it. They don't know. They don't want to challenge, their doctor as they get older, and so they just continue to take these prescription drugs. Middle-aged and older women have also had significant exposure to medical professionals who prescribe opioids. And I just want to mention a little bit on the adolescents, although we're not going to focus really on the elderly or the adolescents, but I just wanted to kind of mention those. If you look at the prevalence of opioid prescription, heroin, illicit, it has increased in adolescents. 2015, nearly 4% of adolescents misused pain relievers. And of those 12 to 17 years old, more than half of them were girls. And I wanted to show you this real quick. If you look at the dark blue in here, most of it is unintentional. A majority of the deaths related to the drug use are unintentional. But if you look a little bit closer, you'll see that in girls, that unintentional is dropped to 70%, and 22% of it is due to suicide. And for boys, it's 86% and only 8% suicide. So although unintentional deaths is the primary thing that we see in adolescents, suicide is a lot higher in girls. And I think there's a lot related to that when you look at some of the issues that teenage girls go through. A lot of it related to some of the things that we're going to talk about with women. So some of the things that we see, gender differences and the impacts of prescription opioid and heroin. There's 2 major things that we see. Women are more likely to experience chronic pain, and the use of prescription opioid pain medications for longer periods and in higher doses. And ironically, women can use smaller amounts for a shorter period of time before they become independent. So those 2 things together are definitely going to create a very quick addiction to prescription opioid as well. Women are also more likely, to be prescribed opioids. The highest rate of opioid prescription is in the reproductive age, 18 to 44. A quarter are privately insured women, and a third are female Medicaid. And, I see a lot of our girls when they get out of prison, they're on Medicaid, they go to their physicians, and their physicians are just giving it to them right and left. And to try to tell an inmate with an addiction to tell her doctor that she can't have it is crazy. But that's what they have to do, because the doctors aren't really understanding that. The ones on Medicaid especially. Middle-class white women are more likely to be prescribed opioids than other races. And a lot of that is known as what we call the physician bias, that they assume there's less risk. It's a personal bias, so I put that in quotes, that there's a less risk of a problem if it's a middle-class white woman. So they are engaged in higher prescription use. So we see that as well in the suburbs as well. Engaged in doctor shopping. That's another one, is that women will basically doctor shop. They will go to multiple prescribers. If the physician won't give them what they're looking for, they said, that's fine, I'll get another doctor, or, you know, I'll talk to my legislator, or I know people, so you can work with me, or, you know, you'll pay the price. So those are some other things. I also, if you look at the bottom, that blue report online, you can see womenshealth.gov. They have a new report that just came out on opioid, and some of this information that I'm telling you right now is also in there as well. It's a really good report to share with your staff. Other things: women are more likely to experience pain, including chronic pain. They're more likely to report it. They are more likely to self-medicate to fix the problem themselves, whether it's physical medication. We'll talk a little bit more about that, stress, anxiety. They're more likely to experience cravings, and some of that has been tied to hormonal imbalances or hormonal issues of some sort. They are more likely to relapse. And the last one is a real big one, that they are more likely to not seek treatment. So a lot of women are not going to go get help, because if they say, hey, I have a problem with this drug, I can't seem to stop taking it, can you work with me? They fear that they are going to lose custody of their children, and their children a lot of times is their number one priority, that they don't want to lose them. So they won't go after treatment. Opioid differences based on also unique characteristics. Women, as we know, experience more trauma, physical and sexual abuse, domestic violence, emotional abuse, PTSD. The social pathways are different for women. The studies show that men tend to start using drugs based on their peers, whereas women, it's a close it's a partner or a close relationship, and in many cases that close relationship can be their mom at a very young age. So we see that the use of the drug is tied to somebody and something emotional. Even in our women's prisons, we don't see so much violent criminal. When you look at what women are in prison for, it's much less violent, and it's much more related to relationships that they don't let go of. And so there's a lot of John Deere letters, or whatever those are called, Dear John letters, I guess. And there's also a lot of breakups and divorces that go on in prison once they realize how much of what they're doing is tied to that relationship. Psychological and emotional stress is also not found as frequently in men as in women, according to some studies. And then a big one is the biological difference. I mean, we all know that when men come into treatment and they start putting weight on, they're very happy. Women come into treatment, that's the first traumatic thing that makes them want to get back out of treatment, or start hustling their physicians. So the biological changes, characteristics in women, weight issues, body fat issues, metabolism, energy, and differences in hormone fluctuations. So state admissions, when you look at substance abuse treatment, you can see we do talk about opioid is kind of a big buzzword right now, and it's something that everybody's talking about. I know that there's a lot of federal funding out there for opioid issues. But the opioid issue, when it comes to women, is not something new. And we also have to look on the Western region, that even more so is methamphetamine. So you can see on the left, in the US, heroin is the highest. And then methamphetamine, and then opioids. On the Western region, meth jumps to the top, and then heroin is right behind that. A lot of what we're seeing over the years is that as the heroin or the opioid is on the rise, kind of hoped over that we would see the methamphetamine start to come down, but that's actually not happened with women. the opioid and is basically coming up to meet the methamphetamine, because for many women, methamphetamine as a pick-me-up, opioid helps them relax, come back down, and so they we're seeing more and more of them using them both together. So I usually, I have a lot of data on Nevada, where I am from, but I did a little comparison, pulled my Nevada data and pulled out North Dakota. I know probably not all of you are from North Dakota, but I wanted to pull this one out as an example. It is very similar, a little less variability, but very similar to Nevada and Utah and some of the other places that I've spoken on the West Coast. And basically what you see here is, I didn't do all of the small drugs. This is from the TEDS data, and this is 2018, so it's not fully out in the report, but they have sort of a preliminary. And when you look at what people are going into, being admitted for in terms of drugs, and you compare the genders, again, you can see the 65-35 is about normal. So alcohol is about what you would expect across the United States. Typically 65-35. In this case, I think it's 66-32. And alcohol plus some other substance, marijuana, are much higher in men. But as you get into the heroin, the opioids, and the amphetamines, you see that it begins to flip. And actually, North Dakota is also one of those states where methamphetamine or amphetamines are actually higher. So it's really one of the only drugs that women surpass men, but now we're seeing it more in heroin and in opioids. So I wanted to kind of throw that out there. I did put the percentages at the bottom, the males 56 and females 43. That's about the average when you look at all of the drugs. So I think there's less. I think in North Dakota, you're actually, mostly you see that about 65-35. So I think that there's actually probably a higher rate of women, it looks to me like, in terms of substance abuse admissions than other states. So something to really consider, to be looking at in your state, is these gender responsive education and treatment. Stimulants, when we talk about stimulants, we're generally talking about methamphetamine, cocaine, ecstasy, nicotine. Another thing that I wanted to mention it's really, really on the rise. Well, I say on the rise, it has been for the last 10 years, but it's getting even greater, is women, particularly in the suburbs, using the ADD or ADHD drugs like Adderall is really the most popular. If you go down to any show in Vegas, and I don't mean like the strip shows necessarily, but probably those two, in those back rooms where women are getting ready to go on stage and they have to be very thin, Adderall is just passed around like candy, and very popular in the soccer moms, so to quote unquote. As you know, ADHD drugs, if you have that, it's going to help you calm you down, but if you don't have it, it can have the inverse effect. So Adderall is kind of known as the suburb version of methamphetamine. Schedule II drug still has high potential for abuse, high potential for dependence, and needs to be under strict regulations for prescription. So why do women use stimulants? Well, these are some of the top reasons. There's a study that I've referenced down here, Brecht, in 2004 was the first big study that came out on this from the UCLA Substance Abuse Center, or Integrated Substance Abuse Center, where they talk about, they did a lot of assessment on women to find out what were the top reasons that men and women used. And men, it was work, so there was some energy issues related to that, but for women, it was definitely elevated mood, but also increased energy, weight loss, loss of appetite, and elevated metabolic, so basically increasing their metabolism. This is part of that study. You can see the males, the highest one was to be able to work more, better sex, and experimental with their peers. For women, the very highest one you can see there is weight loss. the next highest one for women is energy. And then you can also see, you know, more pure for fun or to just to get high. Escape is another one. But clearly energy and weight loss stand out. And when I started this work back in the late 90s, I would spend quite a bit of time down at the women's prison and started seeing what is going on down here with these women that I've never seen before in my life. And I've lived in mostly California and Vegas my whole life. So it was still something unique with these women down there. And what I really started seeing was the fact that these women were developing issues. A lot of them were methamphetamine users and developing issues now that they were forced, so to speak, to become sober. And that's what kind of started my interest in this work, because I realized that if weight loss and energy were one of the big issues that were keeping women using and relapsing, this isn't just a mental health issue. This is also a physical health issue that women need to learn how to better take care of themselves in addition to the mental health issue. And we'll talk about that a little more in just a second. So I did some studies. These are just some of the studies that I did. Measures that we used were, I partnered with Dr. Courtney Warren, who is a clinical psychologist. So some of these were tools that she had recommended that we use. Validated tools, body shape, social, cultural attitudes, Eat 26, which probably most of you are familiar with if you do any work with eating pathology, an intuitive eating survey and a binge eating survey. And then, of course, we did just basic health behavior questionnaire. The IPAC there you see is an exercise, physical activity assessment tool. That's also a validated tool. We did a knowledge survey to see how much they knew, and then we collected biometrics, mostly just blood pressure, weight. We also measured body fat on these women. And we found really the three major things that we found. One is the obvious, that the primary reason women use is because of weight. But also it was a core issue for women in treatment to prevent relapse, and they tended to gain weight when they came in. So if women gained weight when they came in, that became a primary issue for them in order to get out. So they would go through this counseling. I have women that tell me every day, I just can't wait to get out of here. I just got to get this weight off. So the obvious one is the weight concerns. We did learn a lot about that, and that was something we had to address. If you look at the average weight, this is, I'm trying to think when I did this. I think this is 2015 maybe. But it hasn't changed much over the years. I think I've collected data on about 3,000 women, or maybe closer to 4,000 now. And the data doesn't vary very much. But if you look at this data, basically you can see about roughly 65% are either overweight or obese. And these are women that are in prison or in treatment as well. Only a third of them are normal weight, and then a few are underweight, and likely those are ones that have just entered the system. So it is a problem. It's not in their head that they're overweight, but what's in their head is that I've got to get back out of here so that I can start to lose weight. We also looked at asking them. 60% of them were concerned about gaining weight during recovery. 45% concerned that it would be a trigger to relapse, and 35% said they were actually concerned about using drugs to lose weight post-program. So that they would probably, and that's pretty high. I mean, that's 1 in 3 people saying it's very likely that I'm going to go back to using, you know, the meth diet long enough to get my weight down, which we know isn't possible. The second thing that we observed, in addition to weight, is body image disturbances, which goes hand in hand. It's a very strong predictor for eating pathology, which is the next thing that we saw. It's often associated with self-esteem and depression, anxiety, But it is very strong. It goes hand in hand with eating pathology, which is a comorbidity with substance abuse. There's a lot of data on even alcohol and eating disorders, methamphetamine and eating disorders. It's a very, very high. And even though a diagnosed eating disorder may not come up as super strong, if you look at how many women are diagnosed, I think the natural population is probably around 3%, and women in prison is probably around 8%, which is considerably higher. But what we really see, especially if you look at the data on co-occurring disorders, is that women have what we call disordered eating, which is commonly what we talk about. They may or may not be diagnosed, and unfortunately, when you look at, the DSM-5 or something, and it might say, I don't know off the top of my head, that if you throw up twice a week, for 3 months, that's considered diagnosable. But, if you only do it once a week, or you do it twice a week and you do it for a month and then you stop, then that's not considered. But that's still a problem. I mean, women who are throwing up intentionally to lose weight, no matter how often it is a disordered eating behavior, disordered eating pattern that it relates and ties in and keeps them constantly back into the substance abuse or substance use disorders. They do unhealthy dieting, unhealthy eating practices, and then some of them have full-blown eating disorders. Dietary restriction are some of the things that they do: energy and dietary supplements, tobacco, the anorexic and bulimic practices, whether they're diagnosed or what we call a self-treatment, for them to try to address this problem while they're in treatment or in recovery, or when they leave. And it tends to be a gateway back. And this is the thing that I saw probably more than anything when I was in the prison, is that women were trying to figure out. So if I put a treadmill into the prison to allow women to exercise, some women would be on it 3 times a day, or they would stop eating, or they would diet, or they would throw up, and other girls would cover for them while they were in treatment so that nobody knew that they were doing this. And it was a gateway back. There's a lot of research that shows that. There's even research that I won't get sidetracked, but there's a lot of research now about even energy drinks, because it is a supplement. Energy drinks that people are taking, Red Bull or whatever the energy drink is, those are not regulated by the FDA. Those are not like Gatorade or something like that. They are considered supplements. They're a non-food item, so they're not regulated at all by the FDA, so they can put as much caffeine as they want. Unless somebody gets hurt, files a complaint, they're not even going to look at it. So some of the amount of caffeine plant that's in these energy drinks is just fueling something that they've lost in the drug, and tends to be a gateway back. So I really discourage centers and even counselors from bringing in energy drinks and utilizing those in treatment. Here, if you can look at, this was part of a study that I did in 2014, I think. It kind of ranked what they're using, but women are using these unhealthy weight methods. Methamphetamine is right up there in the top with smoking. Then energy drinks, then supplements and diet pills, and then you have all these other things that women are doing at a lower percent, but they're still doing it. So what did we find out from all the studies I did? Basically, that women are concerned with weight gain. It's a major trigger for drug relapse and may increase their risk of reoffending. Concern about using drugs following weight loss was prevalent, given that when many women gain weight, this is a big issue that we have to address during their arrest or their incarceration. And overweight and obese, lack of physical activity, perceived weight concerns, and poor weight management will lead women to self-medicate. Women like to self-medicate to lose weight, and including illicit drug use. So there are some gaps in treatment that we have to look at. And I think the biggest thing is that if we don't address this, if it's left untreated, that it will be a trigger for relapse. So gender-specific programs are warranted. There aren't a lot in this area. But some of the key components that we would need to address would be nutrition, looking at nutritional deficiencies associated with substance abuse disorders, understanding nutrients and their relationship to energy, especially carbohydrates and vitamins. A lot of women are picking up the carbohydrate or the carb trend and don't understand the importance of carbohydrates in their system. So they're self-dieting and understanding that vitamins don't necessarily give you energy. Applied nutrition is another thing that we've learned. Some of my colleagues that are PhDs in nutrition have worked with me on developing ways to address it that's applied. So instead of saying, vitamins and minerals are important for you, we might talk about the things that are good for your hair and good for your skin, and the things that help you, the foods that help you feel better and provide more energy, things that help you, protein that helps you, foods that help you recover better from injury. So we might use that method instead of saying eat protein, eat fats, make sure you have enough this, vitamin B does this, vitamin D does that. So I'm also talking a lot about metabolism and energy balance, understanding what happens to your metabolism when you're using things like stimulants and opioids, and how does that affect your energy balance, and how can that be modified when you get into treatment. Obviously looking at portion sizes related to intuitive eating. A lot of women have lost their ability to really even know. Meal planning, food labels and shopping, more of this or less of this, as opposed to don't eat this and don't eat that. And then family is a big part of what we do. So every lesson that we teach with women includes the family. We don't encourage women to leave their kids at home and go to the gym or go to the grocery store and come back and just tell their family this is what we're eating, or have the kids eat this thing and mom eat this thing, but really rebonding through physical activity, through shopping, taking the kids to the store, allowing kids to be a part of the cooking, changing lifestyles within the whole family unit. We also address physical activity, weight and body composition, understanding what happens to your body when you're using, why you lose that much weight. You're not losing necessarily body fat, you're losing muscle tissue, you have bone loss, calcium deficiencies. Women are amazing when they start to understand this, how they choose to recover going forward. Education is a big part of this because there's so much misinformation out there. And then talking about trauma-informed nutrition, which is fairly new, but trauma-informed nutrition is basically dealing with things like eating pathology. I'm going to switch modes for a second because I looked up, these are some of the questions they ask in trauma-informed nutrition. What is the relationship between adverse experiences and eating habits, food security and nutritional status? How can we work on food insecurity and nutritional health in a trauma-informed way? And how can understanding our relationship to food through a trauma-informed lens support healing, resilience, and whole health? These are the questions that are asked in trauma-informed nutrition. And it addresses eating, food insecurity, disordered eating behavior, and the psychosocial factors that I mentioned earlier. And then, of course, the mental health associated. How many women say, when somebody says, oh, you look really healthy. It's so great to see you now that you're in treatment or that you're in recovery. You look so healthy. And that healthy translates in their brain to fat. So what you're really saying is I'm fat. No, that's not what healthy means, but that's what they hear. So we have to rewire the brain in the same way that we do in other forms or other treatment settings. We have to rewire the brain in the mental health related to exercise and weight and food and how people perceive those as part of their daily lives. So we have a program, it's called Healthy Steps to Freedom. It's actually been around for quite a few years. I wrote a kind of a prototype for this program back in the late 90s, early 2000 out at the women's prison. That's where I started it. When I went to the university, and that was when I was in private business. When I became faculty at the university, I redid the program, published it through peer review in 2009, and then published a few studies on it. And then recently, we just did an update on it because we need to revise it. Unfortunately, or fortunately, I guess I should say, when it comes to nutrition, physical activity, any type of health-related behaviors, there's constantly, things changing in terms of research, in terms of what to eat and how to eat and exercise. So we like to make sure that we're very current on research related to these behaviors. So we revised it the last 2 to 3 years. We just completed it now. It used to be a 12-week program. We reduced it to a 10-week program because a lot of the federal funding now is only for 3 months. So we reduced from 12 weeks to 10 weeks so that women could get in and get through the program as part of their treatment. And you can see some of the things that we address in those 10 weeks. We recommend about 90 minutes to give time for processing. If you were doing a lecture, it would be only 60 minutes, but 90 minutes really allows good discussion. At the prison, we actually run it for a 2-hour program once a week because they're getting meritorious credit. So they actually, it's been approved as an evidence-based program through the Department of Corrections. And so women get early release time. So we really like to target those women that specifically have these issues. Do these help women? They help women or men in general. I mean, choosing healthy lifestyle along with your mental health recovery is a great thing for everybody, but specifically for women that this is an issue, this is really, really critical to their treatment plan. Some of the co-occurring disorders that we see, like if you restrict your food, then if you might start to lose weight, then you start to gain weight when you come back to eating. Gaining weight makes you depressed, so then you might binge. We see co-occurring related to medications, women hustling their doctors. They're saying, I can't take this, it makes me sick, when really what they're saying is, I can't take this because this makes me fat. Or they might say, my friend is using such and such drug and she said that's helping her. Do you think I could switch to that drug? Because what she's really saying is that one makes her thin and doesn't make her gain weight. These women know this stuff. They study too much, they talk too much to each other, and they've learned how to kind of figure out how to maintain their weight while they're in recovery. And one thing just leads to another. And you can't address one without addressing the other problem. Women are depressed because they're overweight. Then they get depressed when they go into recovery. And then after they may try to lose weight, if they don't lose weight, then they're depressed. And it's just a cycle of co-occurring. This is one of the studies that I did back, and this one was quite a while. This was the first one that we did on the 10-week program, or on the 12-week program, and we're in the process of publishing some of the results. Here's some data that I collected in 2018 on the 10-week program. And you can see just in our studies, the average age is about 38. Most of them have children. Weight perception, the self-reported ideal weight, we asked them what is their ideal weight before, and we asked them after the program. We hope that they will choose a higher number, which you can see that they did at pre-post, significantly higher. We also saw an improvement in their nutrition and health behaviors, maybe starting to be more physically active, maybe making better choices related to their diet. We saw improved eating attitudes, which would be looking at more of the sickness associated with eating. Could be throwing up. It could be very, very restrictive dieting. We saw improvements in sociocultural attitudes, how they perceive themselves on a thin ideal internalization scale, and then also their perceived body image, which is more important than what their actual body image is. In intuitive eating, we see positive changes in their intuitive scale. which basically means they're able to listen to their bodies better and not really focus on, how many of this, I shouldn't have seconds, I shouldn't have this many, I control, I only eat this many portion size. All of that thinking drives a person to continue this type of behavior. So we try to teach them to be more intuitive and to relearn that. Binge eating is also very common in these women. We look at a binge eating scale to reduce the severity, and then inactivity as well. I want to just take a minute. I'm just going to pull up a different, I have named this girl Gabriella. I want to just share with you a story, because I think that she's so we get a lot of feedback from women. We get a lot of their stories written, but this one I've shortened it a little bit because it was a little long, but I kind of want to go back. We don't really do case studies, but I do want to share with you an example of a girl who talks through her story. I have some other resources that you can also look at, but this girl gave her story after, and one thing that she mentions in here that you'll hear is that she never knew that there was such thing as bulimia, and she had figured out on her own. I remember her coming into the class and saying, well, I figured out a way to get rid of my food that works really well. And I said, well, what is that? And she said, I throw it up. And I said, well, that, I had to help her understand that that's actually a thing. Like that's a disordered eating behavior, and it has a name, and she had no idea. And it's beyond me to think that people don't know that women don't know this, but they're so consumed within their world. And, I have to tell you too, I go into the courtroom and I see women, go before the judge, and the judge says, well, you mean to tell me that you lost your children, you lost your home, you lost your job, you're sitting in jail because you got fat? Is that what you're telling me? And she kind of doesn't know what to say at that point. And you can believe that the other girls in that courtroom are going, well, I'm not going to say that, but that's true. And a lot of women, when they gain weight, it becomes the drive for trying to get themselves back, get their jobs back, feel good about themselves again, get their man back or their partner or whatever. So anyway, I just want to read this story to you. Let me see if I can pull it up here. I think I have it here. And I've highlighted a couple things that are really stand out to me. But this is Gabriella. She says, I was born in a small city in Central America. On my first birthday, my mom took me to visit her Aunt Maria. She left me and told my aunt she was going to the nearby store. She said she would be right back, but she never returned. So I grew up with my great Aunt Maria, who loved me, cared for me as her own. I was always a skinny little girl, in fact, bullied by my friends for being abnormal. As a teenager, I started developing and filling into my clothes. The comments changed, and everyone told me how beautiful I was. At 15, my great Aunt Maria informed me that we were going on vacation to visit family in Los Angeles. This would be the first time in 15 years, basically her whole life, that I would see my mother again. On the third night, while visiting with friends, we heard a knock on the door, and we were handed a subpoena saying that my Aunt Maria had to appear in court for my mom's custody of me. The LAPD returned me to my mother. I was devastated. I was taken away from the only mom, dad, aunt, uncle, auntie, grandma, and grandpa. My mother took away my whole family in one night. On my 16th birthday, she bought me a grown-up dress that I was so uncomfortable in. She told me I was fat and I needed to lose 15 pounds. I was 5'1", 119 pounds. It took me forever to get basically up to this weight. And now I was considered abnormal because my mom said, in America, skinny is the way to be. She bought me some pills, Dexatrim, over the counter, right? I was afraid to eat. I exercised, but the weight would not budge. She gave me water pills. My weight continued to fluctuate. A few years later, I started making myself throw up, and then I found that there was a word for it, purging, which she had learned in our program. I watched programs on TV with kids that were anorexic. I wish I could have that disease so I could be skinny again. It didn't matter how much weight I lost. I would look in the mirror and see fat, and I hated myself. I met a wonderful guy who always made me feel beautiful and told me how much he loved me. We had a daughter together, and after the baby, I gained weight. My mommy came to the rescue. She found me a place in Beverly Hills that helps you lose weight. My husband didn't understand why I wanted to do it, but he did whatever I wanted and paid a lot of money for me to go. I lost 50 pounds. My mom said, "Oh, you look great." Her fat comments and embarrassing jokes turned to compliments, and it was a relief. So I attended this place for many years. 10 years later, pregnant with my second baby girl, I would make myself throw up and starve so that I wouldn't gain weight. So now she's afraid that she might go back to that. My baby was 5 pounds and so skinny when she was born. I felt so guilty and evil. I gained weight after her birth and tried to go back to the clinic, but they were no longer there. Oops, I lost my place. I didn't know what to do with myself. I continued to purge to keep the weight off. I moved to Vegas. I continued to fight an everyday battle with diet pills and binging. After I had my third daughter, I asked my sister how she lost a lot of weight. She was always bigger than me, and yet she endured my mom's insults as well as others all of her life. So I asked her how she lost the weight. She said she took some pills from Tijuana, Mexico. So I kept insisting we go to Tijuana to get some for me, and she kept putting me off. She finally told me the truth, that the miracle cure for fat is crystal meth, and my brother, who lived with us, was a dealer. All this time, and the cure was right here. She showed me how to use it, what to do. I didn't feel any euphoria, but I just wasn't hungry. I didn't think I was high because I didn't feel anything, though not realizing that this drug was messing with my brain. I started noticing changes. I did things I normally wouldn't do. It started being really scary. I didn't know how to tell my sister that I didn't want this anymore because we developed this false sense of closeness. Finally, we had something in common. I started out lying to her and saying things like, "I don't want any, I just did some last night." So at this point, she has this close relationship with her sister. She wants to quit, but she doesn't want to lose that. So she basically lies to her about using it. Shortly after that, I was arrested. I wasn't using meth, but my hair was tested by the social worker, and now I'm in recovery. Today, I am thankful for being here. It's been a hard struggle going through everything. Listening to the experiences of others made me realize what my sister is going through and where I could have been. I was fortunate that through prayers, God saved my life and my sanity. My children have their mother back. My husband has his wife back. I realized that I have an underlying issue that caused me to go to the lengths that I went to, and it's my weight. I have learned that there's a better, healthier way to deal with this issue. My mother is also realizing the damages that she caused us from her ridiculing and her own twisted perception of what we should look like. My sister is currently homeless, totally strung out on crystal meth. My brother is in jail serving time for selling crystal meth. As for me, I'm happy and thankful to be here. My case will close this May. I'm working on getting my nursing license back and taking care of my kids and my family. I'm the happiest I've been in a long time. I still have issues with my weight, but I'm slowly coming to grips with it thanks to Dr. Annie and the others from the University of Nevada. Obviously, it wasn't the program that fixed her life. It was her treatment combined with addressing this stuff head on. But I wanted to share that story with you because that's a story that I hear every single day. And sadly, some of the things that she highlights are things we address, that body image and sociocultural, that we have to be skinny in America, the binging and the purging. Interesting that her mom and her sister were some of the main people that took her down that road, and not her husband. Sometimes it's the partner, it's the domestic abuse of the partner, but it doesn't always have to look like that. And so I wanted to point, some of those out as well. Let me see. go back. I think that's pretty much the end of my slide presentation. I also wanted to tell you that there's a video that I can send a link to. We had to, because the woman who is in this video is still struggling, so I had to redo the video with an actress, but it's a real story of a woman and her struggle and how it turned to a full-blown eating disorder and how her substance abuse is tied to her eating disorder. So I would encourage you to take a look at that video. I can send the link out to that. And I also wanted to point out Demi Lovato is an example, a poster child of what we see on TV, where women are with mental health. She has a self-proclaimed bulimia, self-proclaimed mental health issues, self-proclaimed eating disorder, body image issues, and the only thing we hear in the media is how Narcan saved her life. And I realize that there's some value to these drugs, but we've got to address what's behind some of these women that are crying out and trying to tell their story. So anyway, hopefully I didn't ramble too long. If you have any questions, I'd be happy to answer any questions at this point.
Well, first, let me thank you, Dr. Lindsay, and say we do have about 5 minutes for questions, so maybe 1 or 2 questions. And please remember to unmute your microphone and turn those questions to Dr. Lindsay.
Hi, Dr. Lindsay, this is Tiffany, and I'm from South Dakota. I just had a couple questions. You focused on the reproductive age, and you mentioned it's about age 18. I'm wondering, I've had a lot of younger kids than that age. Is there a reason we focus on reproductive versus non-reproductive age for women?
When you say focus, do you mean in terms of programming or?
Well, you just had mentioned here that we're focusing on young reproductive female age people, and I didn't know outside of that, yeah. I guess.
So I think I was just mentioning that the data is showing that that's one of the highest uses is the 18 to 25, and it's related to reproductive age, but it's actually, as far as reproductive, happens in younger. We actually did run a program for women, juvenile women. So it's definitely an issue with those women. It just is the data is showing that the opioid use is more tied to 18 to 25. Or actually 18 to 44 really, but mostly in that reproductive arena. But yeah, we have to address this with younger women as well.
Thank you.
Thank you. Are there other questions or comments for discussion?
This is Tiffany again. I just had another one quick question. Within some of your stuff, have you helped some of the women or men define pain and how that really drives why they seek out some of the stuff besides just the weight loss?
Pain, yes, but not just physical pain. Actually, in the 3,000 to 4,000 women that I have worked with over the years, we're seeing a little bit more in terms of physical pain, but it has not been as common as more the emotional pain, that goes along with that. So pain is definitely part of it. Escape from pain, and maybe it's worse here in Las Vegas because we have a lot of women, in the sex trade and things like that too that are caught in domestic violence situations. But definitely pain is a big part of that, yeah.
Dr. Lindsay, I might ask a question. This is David moderating. Thank you for your attention to North Dakota in particular with that slide. And as you may know, Project ECHO is very focused on rural communities. A lot of rural communities certainly are in Nevada as well. I've had the opportunity to travel the state, and it's a very large and rural state apart from Las Vegas. Any of your studies that you might think to be able to apply, particularly to small towns of 2,000 or 3,000 people, isolated, without at least some of the local resources that you might find in a metropolitan area?
Well, Yes, actually, I just published a study recently. It's not necessarily in the addiction arena, but I studied 4 or 5 communities as a partner with a big grant from Oregon State as well, in looking at the differences between rural and urban communities in terms of physical health, what's available for physical activity and nutrition. And there are some very tough differences there in terms of access to, healthy foods and access, or you would think in rural areas they walk a lot, but they end up driving more because it's too far to walk. So there's a lot of issues that make it difficult to live a healthy lifestyle in the rural communities. But addiction is huge in the rural communities, and I think again, to offer this type of treatment, education, because education is a big part of it. Education is probably the first thing. I guess it goes hand in hand with access, but we're actually trying to put this program online so that people can take it, that if they don't have instructors, that women can take these, like in rural areas, online by themselves as well.
Yes, I would agree. I think, we've done some education and talked to patients about how do you exercise in a rural area. Oftentimes the answer might be, well, if it's 10 degrees below zero or 20 degrees below zero, which it can be quite regularly here in North Dakota, just go to the local mall. But if you're in a rural area without a local mall, how do you look at creative ways of being more active if it's particularly a difficult climate many months of the year and you don't have some of those other resources? So, well, I would encourage the ongoing discussion about how to look with a rural lens and also in some of these more extreme climates as well.
Yeah.
Is there any last comments or questions in the last minute? If not, again, I want to thank you, Dr. Lindsay, and also remind everyone who's participating today to complete the post-test and evaluation. And don't forget to sign the roster at your local site with your coordinators so that can be sent in for your continuing education credits. And again, Dr. Lindsay, appreciate your presentation today. And Julie, I'll turn it to you for any last announcements.
I don't think we have any further announcements at this time.
Thank you, everyone, for joining us.
Thank you.